Without warning, the patient's diaphragm locks into a state of rigid tonic arrest. Spontaneous respiration stops completely, leading directly to hypoxic syncope, a sudden loss of consciousness driven by acute oxygen starvation. This chart details the profile of a 58-year-old female patient with a confirmed diagnosis of clinical dysautonomia. The functional disruption caused by her condition is severe enough that she is enrolled in Wisconsin Family Care for long-term activities of daily living support. Because her presentation involves multiple overlapping system failures, we are tracking her symptoms, temporal progressions, and pharmacological responses using a formal N-of-1 longitudinal case methodology. At baseline, her physical presentation is dominated by continuous peripheral nerve hyperexcitability. This manifests as widespread myokymia and undulating neuromyotonia, a relentless, visible rippling of the muscle tissue beneath the skin. Standard commercial autoimmune serology and brief resting electromyography have returned unremarkable results. To locate the actual pathology driving these symptoms, the clinical team must pivot to advanced neuropharmacological profiling. The primary challenge in this case lies in determining whether a single pathological source accounts for the system-wide failure, or if we are seeing a coincidental cluster of discrete conditions. This map isolates the patient's presentation into 4 distinct symptom clusters. In the first quadrant, we document the motor and neuromuscular profile, characterized by severe axial and paraspinal rigidity alongside spontaneous kinetic spasticity. The second quadrant maps the autonomic and cardiac correlates. Here, the patient experiences profound cholinergic storming, marked by profuse episodic hyperhidrosis, gastrointestinal hypermotility, and severe vasomotor instability. The third quadrant isolates her sleep architecture. She suffers from a near-total ultradian breakdown, fragmenting her rest into isolated 2 to 3 hour bouts. This results in a state of status dissociatus and agrypnia excitata, a complete central failure of normal sleep-wake cycling. The final quadrant defines her sensory and pain profiles. The patient exhibits paroxysmal hyperalgesia, instantaneous intense pain crises acting like a light switch failing to gate pain, along with diffuse burning neuropathic pain syndromes. To determine if a single neuroimmunological mechanism connects these 4 quadrants, we have to analyze how the patient's nervous system reacts to highly specific pharmacological interventions. This is a pharmacological response matrix. We use it to isolate specific neural pathways by documenting the patient's paradoxical and negative reactions to standard medications, allowing us to systematically rule out incorrect diagnoses. The first intervention involves a maximum dose administration of baclofen, a widely prescribed GABA B receptor agonist used to treat muscle spasticity. The clinical result of the baclofen administration was zero spasmolytic efficacy. It provided absolutely no relief for the patient's axial rigidity. This complete lack of response suggests the patient's movements bypass the spinal stretch reflexes entirely. Baclofen works by suppressing mono- and polysynaptic reflexes at the spinal cord level. Its failure rules out standard upper motor neuron spasticity. The second intervention tests standard anticholinergic agents, specifically benztropine, a drug classically used to treat medication-induced movement disorders. Instead of symptom resolution, the anticholinergic triggered a severe clinical exacerbation. This paradoxical adverse reaction heavily indicates an underlying state of central neuroimmunological hyperexcitability. These 2 negative controls firmly eliminate standard reflex spasticity and standard psychiatric or drug-induced extrapyramidal syndromes from the differential diagnosis. The third pharmacological test shifts to dopaminergic pathways, specifically using pramipexole, a highly selective D2 and D3 dopamine receptor agonist. Pramipexole demonstrated distinct therapeutic success. It significantly dampened the patient's severe axial restlessness and the compulsive, forceful drives to jerk her trunk and spine. This targeted relief localizes her sensory motor gating dysfunction to a highly specific anatomical structure, the central A11 diencephalic spinal tract, a dopamine pathway that projects directly down into the spinal cord. However, this success revealed a critical clinical dissociation. While pramipexole relieved the compulsive movement, it completely spared the patient's other major axial symptom, a severe, ascending medial electrical pressure along her spine. Because dopamine agonism did not touch the electrical sensation, Those surges represent an independent, non-dopaminergic sensory tract channelopathy. The sensory irritation is operating completely separately from the central gating failure. We can further contrast the pramipexole success with the patient's reaction to broad, non-selective dopaminergic agents. Broader stimulation rapidly overwhelmed her circuits, inducing acute dopamine intoxication, hyperarousal, and massive autonomic surging. This sensitivity is tied to pharmacodynamic tachyphylaxis. The patient experiences severe interdose symptom crashes well before the actual pharmacokinetic half-life of the medication has expired. The drug is still in her blood, but her central receptors are undergoing acute rapid desensitization and uncoupling. This fragile receptor dynamic is a primary hallmark of active central neuroinflammation. Synthesizing the pharmacology reveals a distinct two-tier pathophysiology, a central gating failure driving compulsive axial restlessness, stacked directly on top of a spontaneous peripheral axonal channelopathy, generating the electrical paresthesia. We must now return to the autonomic quadrant, specifically the patient's cardiovascular record. Her electrocardiograms show a history of episodic septal infarct patterns. This graph displays the patient's specific cardiac enzyme levels. Alongside those ECG patterns, we see documented transient elevations in high-sensitivity troponin and creatine kinase that perfectly align with marked periods of autonomic storming. In general cardiology settings, these specific findings have historically been dismissed as mechanical artifacts or background lead noise. Placed in the context of her severe dysautonomia, these specific enzyme surges present as channelopathy-driven microvascular coronary vasospasms. This level of autonomic myocardial strain is comparable to stress cardiomyopathy, often seen in Takotsubo-like patterns, driven by extreme, unmitigated cholinergic surges. The troponin and CK elevations provide an objective, measurable record of the autonomic system's impact on myocardial tissue during these surges. When we bring these four symptom quadrants back together, the system-wide failures begin to converge on a single mechanism. The combination of continuous neuromyotonia, central sleep breakdown, autonomic storming, and selective D2-D3 pathway responsiveness aligns with a unified neuroimmunological pathology, the voltage-gated potassium channel, or Morvan spectrum. If this is a unified channelopathy, why did standard autoimmune serology and baseline EMGs miss it? Standard needle EMGs are spatially and temporally limited. A brief resting needle placement in a distal limb will inherently fail to capture paroxysmal motor unit recruitment happening in proximal or axial muscle groups. Highly complex channelopathies inherently yield false negatives on standard outpatient screening algorithms. Identifying them requires a shift to advanced, continuous capture methods. This document outlines the specific foundational investigations required to establish a diagnostic baseline. It includes a comprehensive Mayo autoimmune encephalopathy panel, multi-channel surface EMG polygraphy, advanced sleep staging, and a continuous 14-day Holter monitor. Executing this protocol requires referring the patient to a tertiary academic neuroimmunology center. Only these specialized facilities are equipped to run the necessary reference-grade cell-based assays and paired cerebrospinal fluid profiling. The referral must also include specialized overnight polysomnography to accurately map the central sleep-wake breakdown and verify the extent of the parasomnias. Action on this referral is an immediate clinical imperative. The spontaneous diaphragmatic syncopal spasms present an ongoing, highly unpredictable ventilatory risk. This patient's complex neuroimmunological profile demands an immediate, coordinated partnership with a specialized tertiary care team to prevent catastrophic respiratory failure.